This is our topic today, liver and kidney diseases. So this is a very important topic, and I'll discuss it under the following sectors: serum bilirubin and kidney dysfunction, and the relationship between bilirubin and phosphorus, bile cast nephropathy as extension of the value of serum bilirubin, acute kidney injury in liver disease, cystic disease, hepatitis E, does it affect kidney? This will be an interesting sector. And the kidney dysfunction after liver transplantation, how to treat hepatitis C, the drugs, and their interactions, oxalosis, and lastly, Stuffer syndrome. Let me discuss serum bilirubin and kidney dysfunction. The starting journey is from this 1,363 Korean adult cohort. If you look here, they found that the lower the serum bilirubin, the lower the estimated GFR. So the relationship between serum bilirubin and GFR, estimated GFR, is a direct relationship. And serum bilirubin here is within normal range, but the lower value is associated with low GFR. And if you look here, the lower the serum bilirubin, the higher the degree of proteinuria. This means that the relationship between serum bilirubin is and 24-hour urinary protein is inverse relationship. Another study shows that the lower serum bilirubin, here if you look here, to this is the stage 5, and this is the total bilirubin 0.3, and this is including patients with hyperbilirubinemia, but this excludes the patients with hyperbilirubinemia. Again, here the serum bilirubin is very low, 0.36 milligram per deciliter in stage 5 in comparison to 0.5 within stage 1. This means that hypobilirubinemia might be a possible risk factor of end-stage kidney disease independent of estimated GFR. Another study showed that low serum bilirubin concentration is a predictor of chronic kidney disease. And this is the last study in this sector showing the same. This is from Japan, including patients with stage 3, 5 to 6 chronic kidney disease. And they classified the patients included into 3 tertiles according to the value of serum bilirubin, total bilirubin. The highest group of serum bilirubin between above 0.6 within normal range but above 0.6 milligram per deciliter. Middle group, serum bilirubin between 0.3 to 0.6, and the lowest group serum bilirubin is less than 0.3 milligram per deciliter. What is the relationship between this serum bilirubin strata and development of chronic kidney disease? The lower the serum bilirubin, the higher the risk of development of chronic kidney disease and the progression. This and when we look at this table, the reference point is highest bilirubin group, which is 0.6 milligram per deciliter or above. If serum bilirubin is middle, 0.3 to 0.6, or lowest group below 0.3, and we will look at this data to the hazard risk of renal outcome. In model 1, they adjust the values for age and sex. If they adjust to age and sex, you'll find here the middle bilirubin is associated with 6-fold higher hazard risks for renal outcome, and here 10 folds. And if you look to model 1, 2, when they add to the age and sex, the adjustment for smoking, diabetes, hypertension, dyslipidemia, again still very high hazard risks for the middle and the lowest group. And after adjustment for the age, sex, smoking, diabetes, hypertension, dyslipidemia, plus the use of immune suppression, use of RAS inhibitors, and proteinuria, hemoglobin, and estimated GFR, and serum phosphorus, again, still hazard risk for renal outcome is 3-fold in the middle bilirubin group and more than 4 in the high group, in the low group. This means that the lower the serum bilirubin, the higher the risk of development of more progression of chronic kidney disease. The question why? The answer is serum bilirubin in the normal range is considered as one of the defense mechanisms of the body against oxidative stress, to the extent that the hypothesis of atherogenic Gilbert syndrome was considered a strategy of reducing vascular and cancer risk by increasing plasma unconjugated bilirubin. And this by the use of probenecid, because probenecid inhibit UDP glucuronide transferase and increase indirect bilirubin, or rifampicin, which inhibits the uptake of indirect bilirubin by liver. But again, I don't recommend this approach because drugs have their toxicity and the side effect. So again and again, the concept is the lower the range of serum bilirubin, the higher the risk of chronic kidney disease. And so we can add hypobilirubinemia to the non-traditional risk factors of chronic kidney disease and its progression. The second point in the relationship between serum creatinine and bilirubin is the model for end-stage liver disease, which is known as MELD score. Here, the MELD score depends upon the calculator and for end-stage liver disease, not appropriate for patients under the age of 12. And this is how the calculator was created and done. You just here both the age, add the input for age in years, creatinine milligram per deciliter, bilirubin, INR, etc. And here, if we have this data and creatinine is 1, MELD score is 27. If the data is the same but creatinine increased to 3, MELD score is 37. Here I want to just to say that the highest creatinine to be added is 4, just 4. If you have a patient with creatinine 10, we just vote 4 as the highest value of creatinine in this model score. So here the value of MELD score, the higher the score, the lower the 3 months survival. So this you can see here, if you are here, the mortality is the rule. What about the serum bilirubin and phosphorus? Hyperbilirubinemia may be associated with false hyperphosphatemia because of the lab error. And the best way is to look at the methodology, because some new autoanalyzers may help this situation and giving the correct serum phosphorus. What about bile acid nephropathy? Bile acid nephropathy or cholemic nephropathy. It is the common pathological finding for kidney injury associated with severe liver dysfunction. And if you look at these 44 cases, the higher the serum bilirubin, total and direct, the higher the risk of bile acid nephropathy. So these 24 patients who had bile acid nephropathy, serum bilirubin, the total was 26, and here in the comparison to 15 in the patients without bile acid nephropathy. And this is a typical pathology of bile acid nephropathy. Here this is hematoxylin, and you see, you find the reddish color here reflecting the congestion at vasa recta, and this is the nature of the bile acid and the bilirubin by the whole stain. So the whole stain is the specific stain for bile acid. And this is an autopsy specimen showing the condensation and concentration of the bile at the medullary pyramids, and where this is the natural concentration of the bile. How to differentiate? The differential diagnosis of bile acid nephropathy include hemolysis associated kidney injury, rhabdomyolysis associated kidney injury, bile acid nephropathy, acute tubular necrosis, and light chain cast nephropathy. This is the clinical data, and this is the light microscopic finding, and here the special studies that discriminate the etiology. Here the immunohistochemistry for hemoglobin, here the myoglobin immunohistochemistry, and holistin, as I mentioned, highlight bile pigment, and here acute necrosis cast failed to stain for myoglobin or hemoglobin. A light chain can be discriminated by immunofluorescence. You can find either kappa in hyperintense or lambda hyperintense. Again, one of the important causes of bile acid nephropathy that we should take care of is the use of drugs like stanozolol, which is used by amateur for bodybuilding. So we should avoid the use of this drug that is used from the black market. And also I recommend against the anabolic steroids for bodybuilding because it may be complicated by acid nephropathy. The most important sector in this presentation is AKI in liver disease patients. And this article, this is a position paper for diagnosis and management of acute kidney injury in patients with cirrhosis, as revised consensus recommendations of the International Club of Ascites, ICA. It's very important to be read because it uses the same definition of KDIGO, definition of acute kidney injury. So baseline creatinine is very important. If we have a value of serum creatinine obtained in the previous 3 months, when available, can be used as baseline of serum creatinine. In patients with more than one value within the previous 3 months, the value closest to the admission time to the hospital should be used. In patients without previous serum creatinine value, the serum creatinine on admission should be used as baseline. This is a very important, because the most important criterion for definition of acute kidney injury is the presence of baseline creatinine. And then the definition, we can say the patient develops acute kidney injury if creatinine increase, serum creatinine increases by 0.3 milligram per deciliter, or increases in serum creatinine by 1.4-fold to 2-fold from the baseline. And stage 2, increasing creatinine above 2-fold to 3-fold. Stage 3, increasing 3-fold or reaching 4 milligram per deciliter, or an acute rise, acute increase more than 0.3, or initiation of renal replacement therapy. So again, these are the same definition of KDIGO. KDIGO 0.3 within 48 hours, 1.5-fold of creatinine to 2-fold within 7 days, and the stages as I mentioned. Progression, if the patient progresses from one stage to the higher stage, this is progressor. And regression, if the situation regresses from higher stage to the lower stage. And then the response to treatment, no response, no regression. Partial response, regression of AKI stages with a reduction of serum creatinine. And the full response, return to a value within 0.3 milligram of the baseline value. So we should put in our mind all these definition. Again, this is the KDIGO definition of acute kidney injury, and here the International Club of Ascites take the same definitions. One of the most important point is how to define hepaturenal syndrome, because if we give the stamp of diagnosis of hepaturenal syndrome, this has a meaning in the outcome of the patient and in the treatment strategy. So before saying hepaturenal syndrome, we should fulfill the following criteria. 6 criteria should be fulfilled before definition of hepaturenal syndrome. We should have cirrhosis and ascites. We should have the diagnosis of acute kidney injury based on the International Club of Ascites and acute kidney injury criteria, as I mentioned in the previous slide. No response after 2 consecutive days of diuretic withdrawal, and the plasma volume expansion with albumin 1 gram per kg per day. Absence of shock. So if you find a shock state, don't diagnose hepaturenal syndrome. No current or recent use of nephrotoxic drug like non-steroidal anti-inflammatory drugs, aminoglycosides, iodinated contrast media. No macroscopic signs of structural kidney injury. So we should have absence of proteinuria more than ½ gram per day. We should have absence of hematuria exceeding 50 red cells per high power field. Normal finding on renal ultrasounds. So these are the 6 criteria that should be fulfilled before diagnosis of hepaturenal syndrome. Again, diagnosis of cirrhosis and ascites, diagnosis of acute kidney injury according to the International Club of Ascites. No response after 2 consecutive days of diuretic withdrawal and volume expansion by albumin. Absence of shock. No current or recent use of nephrotoxic drugs. No macroscopic signs of structural kidney injury. Sometimes we look at the biomarkers to establish the diagnosis. So patients who fulfill this criteria may still have structural damage, such as tubular damage. Urine biomarkers will become an important element in making a more accurate differential diagnosis between hepaturenal syndrome and acute tubular necrosis. The hepaturenal syndrome is a very important issue because it's associated with poor prognosis. Since antiquity, Hippocrates stated that when the liver is full of fluid and this overflows into the peritoneal cavity so that the belly becomes full of water, death follows. The only issue that improves this outcome is the presence of liver transplantation nowadays. This is a patient with severe intense ascites, as you see, and the dream of this patient is to have urine. We have two types of hepatorenal syndrome, and I think you can find in some literature 4 types or more, but the most important are type 1 and type 2. In type 1, there is a doubling of serum creatinine within 2 weeks, and type 2, renal impairment gradually progresses. And there is a difference. So in the outcome, for hepatorenal syndrome type 1, the survival is 10% survival in 90 days, in 3 months, without treatment, without liver transplantation, and without supportive treatment. Median survival here is 6 months for type 2 hepatorenal syndrome. How to manage? The management. Well, I should look at the stage of acute kidney injury. If I deal with the stage 1, I'll start from this direction. If I have the patient with stage 2 or 3, I start from this direction. So in stage 1, I start with close monitoring, remove risk factors, withdrawal of nephrotoxic drugs, vasodilators, non-steroidal anti-inflammatory drugs, withdrawal of diuretics, treatment of infections when diagnosed, plasma volume expansion in case of hypovolemia. So either the patient, the situation resolved, so just a close follow-up, the patient becomes stable, further treatment of acute kidney injury decided on case by case, or the patient progresses. If the condition progresses, we should move to the side of stage 2 and 3. Or if the patient from the beginning in stage 2 or 3 acute kidney injury, withdrawal of diuretics if it is not withdrawn, and start albumin 1 gram per kg per day for 2 days. You may have response. If the patient responds, go to this direction. If there is no response, and the condition meets the criteria for hepatorenal syndrome, treat as hepatorenal syndrome by vasoconstrictors and albumin. If not, give a specific treatment for other acute kidney injury phenotype. What's the pathogenesis of hepatorenal syndrome? The pathogenesis moves through these ways. So the end result is splanchnic vasodilatation and renal vasoconstriction, and not only that, but you can find coagulopathies, cardiac dysfunction, cirrhotic cardiomyopathy, circulatory failure, relative adrenal insufficiency, hepatic encephalopathy, and all these factors lead to reduction of effective arterial blood volume, leading to hepatorenal syndrome. Again, this slide shows the abnormalities: decrease the cardiac output, decrease the vascular resistance, splanchnic vasodilatation, relative adrenal insufficiency, activation of endogenous vasoconstrictors, gastrointestinal bacterial translocation, systemic inflammation, and the use of nephrotoxic drugs. All these are the big enemies that lead to renal dysfunction in cirrhotic patient. Look at this slide. Here you will find peripheral defects in this angiography, but what happened here? This is the normal vessel up to the end of the kidney, but this is, you'll be astonished when you know this is autopsy angiography. So after the patient dies, all the vessels are okay now. Before I'm going to discuss management of hepatorenal syndrome, we should think of the differential diagnosis of hepatorenal syndrome, which is pseudo-hepatorenal syndrome. So acute kidney injury in a patient with cirrhosis may be predominant tubulointerstitial involvement or predominant glomerular involvement. So the causes may be infections like sepsis, leptospira, brucella, tuberculosis, Epstein-Barr, hepatitis, A virus, here hepatitis B, C, HIV, schistosoma. Drugs, like all these drugs, can lead to interstitial nephritis. Toxins, like all these, can lead to interstitial nephritis. Sarcoidosis, Sjogren syndrome, a systemic disease, and here lupus, vasculitis, cryoglobulinemia, amyloidosis, circulatory failure, malignancy, congenital genetic defects, and miscellaneous causes here and there. So we should put in mind the wide scope of differential diagnosis. What about serum creatinine in cirrhosis? Serum creatinine is underestimates renal dysfunction in advanced cirrhosis. Why? Because of muscle wasting, and we know that the muscle is a source of creatine and be transferred by the liver into creatinine. So the second point is the effective lower production of creatinine and large distribution of creatinine by edema and increased tubular secretion of creatinine. Serum bilirubin again interferes with assays of creatinine. So for all these reasons, serum creatinine underestimates the degree of renal dysfunction and advanced cirrhosis. So we may think of alternative to creatinine like cystatin C, urinary biomarkers, resistive index, and these are the advantages and disadvantages of each one of them. I am going to concentrate on FeNA. What is FeNA? It is a fractional excretion of sodium. How to calculate FeNA? By dividing clearance of sodium by clearance of creatinine. So it is U sodium multiplied by plasma creatinine, serum creatinine, divided by U creatinine multiplied by plasma sodium. Usually in perirenal elements it is less than 1%, but here in hepatorenal syndrome FeNA is very low because hepatorenal syndrome is characterized by extreme sodium avidity with fraction excretion that is less than 0.1%. If you find FeNA less than 0.1%, this increases the likelihood of hepatorenal syndrome. And the other biomarker in urine may include NGAL, interleukin 18, kidney injury molecule 1, LF liver fatty acid binding protein, albuminuria. So here the demarcation is you'll find the values are very high in acute tubular necrosis. Again, the fraction excretion of sodium is very low in hepatorenal syndrome, but it doesn't discriminate between perirenal azotemia and acute tubular necrosis. The values in acute tubular necrosis for NGAL and interleukin 18 and others are very high, to the extent that if you find 4 markers positive elevated, this increase the risk of diagnosis of acute tubular necrosis by 13-fold. So again, the biomarkers may help us for better and accurate definition of hepatorenal syndrome. How to prevent the occurrence of hepatorenal syndrome? By avoiding drugs that reduce renal perfusion or nephrotoxic substances, to minimize exposure to organ iodinated contrast agents. Intravenous albumin is recommended for volumic filling after large volume paracentesis by considering 8 gram albumin for each liter of ascites removed. Diuretic therapy should be suspended. Bentoxifillin as drugs, anti-TNF activity, antibiotic prophylaxis, intravenous albumin administration, adrenal insufficiency should be identified and treated, drugs. Dosages and drugs should be used by wisdom, and here this is the list of the drugs to be avoided. Avoid the use of non-steroidal, avoid the use of S inhibitor and angiotensin 2 receptor blocker, especially if creatinine is high. Stop diuretics or use them cautiously. Use cautiously and pay attention to the use of laxative, because diarrhea may increase the occurrence of hypoperfusion. Aminoglycoside should be avoided. Contrast media should be used with caution. Beta blocker, careful titration, and the caution at elevated creatinine and low blood pressure. How to treat hepatorenal syndrome? To support the hemodynamics by vasoconstrictors, to vasoconstrict the splanching vessels, and in the same moment we give albumin. The best drug, as you see here, is terlipressin. The mechanism of action is through vasopressin analog, and the dose is 1 milligram intravenous every 4 to 6 hours, and to be increased to 2 milligram every 4 to 6 hours. If there is no improvement in serum creatinine, decrease by 25% by day 3. So if there is no any response, increase the dose up to maximum 12 milligram per day, as long as there are no side effects, and the maximal treatment is 2 weeks. If you don't have terlipressin, you may use noradrenaline, norepinephrine as alpha adrenergic agonist, and the dose is 0.5 to 3 milligram per hour as continuous infusion, and it is treated to achieve 10 millimeter mercury increase in mean arterial pressure, and it requires intensive care unit. And then midodrine and octreotide. Midodrine is alpha adrenergic agonist given orally 7.5 3 times per day, and it can be increased up to 12.5 milligram 3 times daily. Somatostatin analog octreotide in a dose of 100 to 200 microgram subcutaneously 3 times per day. So these are the vasoconstrictors that may be used for treatment of hepatorenal syndrome. Regarding terlipressin, is there a difference between intravenous infusion and IV boluses? One of the advantages of terlipressin over the first one in this group, ornepressin, is ornepressin should be given intravenous infusion, but terlipressin can be given boluses. But this study is accepted. Study is an accepted article showed that given terlipressin but the same dose of intravenous boluses per day is effective as boluses and more safe, because the side effects in the infusion group is significantly lower than a bolus group, and the side effects of terlipressin may include intestinal ischemia, peripheral ischemia, circulatory overload, angina pectoris, arrhythmias, arterial hypertension, persistent diarrhea, and others. Another study showed that terlipressin and albumin is comparable to dopamine furosemide and albumin hepatorenal syndrome. And this another study showed that albumin plus terlipressin are superior to midodrine and octreotide plus albumin. So this is shows superiority of terlipressin over the other vasoconstrictor. A very important point is the volume of albumin. This is the meta-analysis of 19 studies. 8 studies are randomized control studies, 8 studies prospective, and 3 studies retrospectives, and all these studies included 574 patients. As you see, the bigger the volume of albumin, the better the survival. But the patient situation is very important, because sometimes you cannot give the albumin for patient with manifest volume overload, crepitations, and very high central venous pressure. When you give albumin and vasoconstrictor, what is your target? To treat to target here, this study shows that if you increase the mean arterial pressure by just 10 millimeter mercury, you reach your goal. And if you increase the mean arterial pressure above 10, this will not add any further benefit. Regarding type 2 hepatorenal syndrome, the question is, could we treat the patients who suffer from type 2 hepatorenal syndrome like type 1 by terlipressin, albumin, etc.? The answer is no. This is an evidence-based treatment approach for hepatorenal syndrome. The best treatment is liver transplantation. Again, even if acute kidney injury or hepatorenal syndrome, the kidney recovers from this acute renal failure, we should put this patient in the consideration liver transplantation, because we are dealing with the compensated liver state. But we should think of terlipressin and albumin or other vasoconstrictor drugs and albumin just to support the patient until we have liver transplantation. But for type 2 hepatorenal syndrome, just therapeutic paracentesis should be offered to cirrhotic patients with refractory ascites who don't qualify for treatment of TEPS. And TEPS should be considered in all patients with hepatitis renal syndrome type 2 and refractory ascites. Again, as I mentioned, the treatment of hepatorenal syndrome is liver transplantation. The question is, it is only liver transplant or liver and the kidney? Here, the secret is in this word, timely. Timely means the early liver transplant, because every day delay in liver transplantation decreases the chance of reversibility of kidney function by 6%. This is a very interesting algorithm. If you have end-stage liver disease and the GFR is less than 30 milli per minute for more than 4 to 8 weeks, it is better to proceed with simultaneous liver and kidney transplant, combined liver and kidney. If even it's not 4 to 8 weeks, but there is proteinuria above 2 grams, we may think of simultaneous liver and kidney. If no, but kidney biopsy shows more than 30% interstitial fibrosis or global sclerosis, think of simultaneous liver and kidney. Even if no, and there are risk factors for renal diseases like hypertension, diabetes, we may consider liver and kidney. So this is, if you don't have all these, only treatment is only liver transplantation. The question, can we do renal biopsy, or there any indication for renal biopsy in a patient with advanced liver disease? The answer, if you are dealing with acute renal failure and we are sure of diagnosis hepatorenal syndrome or acute necrosis, biopsy is not indicated, except if there is abnormal duration and no recovery, or the candidate for liver transplantation and suspicion of superimposed chronic kidney disease. If you are dealing with chronic renal failure and the GFR is less than 15 or above 60, no indication for renal biopsy. And when we think of renal biopsy, we should be cautious because of increasing risk of bleeding with the presence of coagulopathy. So we may do the biopsy under fresh frozen plasma and INR to be less than 1.5. Some authors recommend transjugular renal biopsy. I know transjugular hepatic biopsy is famous, but some centers do transjugular renal biopsy. Regarding the extracorporeal support in liver failure, I think the solid indication is to support the patient as a bridge for liver transplantation. And as you see, the extracorporeal support include non-cell-based systems and a cell-based system. Non-cell-based system include intermittent, extended, and continuous dialysis technique, hemoperfusion techniques, hemodiabsorption, plasma exchange, plasmapheresis, plasma filtration absorption, selective plasma filtration technologies, CPET, albumin dialysis like molecular adsorbent recirculation.